All right. Hello, everyone. Welcome to the January 2023 edition of SSAT Mentor of the Month. Today, we have the distinct honor of welcoming Dr. Rebecca Minter, who needs no introduction. She is the A.R. Curreri Professor and Chair of the Department of Surgery at the University of Wisconsin School of Medicine and Public Health. Her clinical practice is in the areas of pancreatobiliary and gastrointestinal surgery, and she's recognized as a clinical leader in her field, as well as for her research work in surgical education and academic surgery. She previously served as chief of the HPB divisions at UT Southwestern and the University of Michigan. She's also a past president of the HPBA, SUS, and the Fellowship Council, as well as the current DEI officer of the IHPBA Education and Training Committee and a board director of the American Board of Surgery. So Dr. Minter, thank you so much for joining us today.
Happy to be here. Thanks for the invitation.
Absolutely. Our topic today is surgical culture, and given your numerous leadership roles, both at the institutional and the national level, and your current position as chair, I would imagine that you've seen every side of what culture in surgery is, was, and strives to be. So I wanted to start by kind of addressing the elephant in the room, which is that many people, medical students, colleagues in other specialties, may still view surgery as having an intimidating, malignant culture, which often influences how they interact with our field. Do you think this view is justified? And if so, what can we do to reform or dispel it?
Absolutely. I think, stereotypes develop for a reason. So I think it's fair to say that the stereotype probably exists over time because there was at least some truth to it at some point. I think that we have all worked really hard. Certainly in my department, there's a zero tolerance expectation around how we behave and how we treat each others and demonstrating respect for others at every level. And I think that it's going to take time for us to dispel that myth. The only way that we can dispel it is by how we show up. And I would say that perhaps the most important influence of our medical students is how our residents show up, how our fellows show up, what those interactions look like, how they see the residents being treated, how they see us interact with other colleagues in other disciplines, how we talk about colleagues in other disciplines. All of those things relate to how we build respect. It takes a long time for a stereotype to change, and I think that it probably is contextual. I suspect there probably are some places where, not just in the Department of Surgery, there's a toxic culture, but I would like to think it's not unique to our discipline, but really is much more what is the culture of a place. If you're in a place with the right culture, then those toxic behaviors are unacceptable, whether in a Department of Surgery or Department of Medicine, or the pediatricians are usually pretty nice wherever you are. But I think it really is up to us to change that perception.
I think the first part of what you brought up was really important in terms of starting with the residents and the trainees. And as a trainee myself in this stage of my career, I'd be curious to ask you what you think about the education for us at this stage of our career. So we know that culture is set at any level of the hierarchy in medicine and surgery. And as you already alluded to, trainees often learn habits and behaviors by example of our faculty, and then the students and the junior residents will learn from us. So how can we coach trainees to themselves lead by example and to model these behaviors that may turn the tide, if you will, in terms of our discussion on surgical culture?
I think, obviously the hidden curriculum, as they like to call it, in terms of what we observe and how we act, it comes from the top down and the bottom up. So I think that it's incumbent upon the faculty to demonstrate behaviors that should be emulated and not those that should not. I think it's very hard. I'm a parent as well, and it's very hard to, say, do as I say, not as I do. That works like 0% of the time. So I think at the end of the day, it's how we show up and how we behave, and it's holding each other accountable. I do think that the residents will emulate the behaviors of the people that they really admire and respect. And if those behaviors are not ones that demonstrate respect and collegiality and professionalism, then those will be the behaviors that they carry forward. And then, the cycle continues. So it does have to stem from us holding ourselves to a very high standard. And likewise, the residents and the fellows holding themselves to a very high standard in terms of how they treat the medical students, how they interface with nurses, and again, how they talk about the other specialties. It's interesting, you hear one of the most common things I hear in medical student feedback and our, annual reports in any institution I've ever been at is how distasteful the medical students find it when we, talk smack about other specialties.
Yeah.
They don't find that to be funny. They find it to be disrespectful. And so that's just a simple example. I think also, something as simple as, swearing in the operating room or stomping your foot can be an example that we set for our residents. And then they find that's acceptable. And then when you have a conversation about trying to change those behaviors, I think I hear frequently from surgeons, well, all surgeons swear in the OR. And I'm like, well, not all surgeons, and that's not an acceptable behavior anymore. I think we've gotten to where throwing things is not acceptable anymore, but now we got to work on the language that we use and the conversations that we have in the operating room. And that's an environment where there's a lot of ears listening, and they're setting an example in that setting in ways that we may not even realize. And then that gets emulated going forward. So it really is, everyone has to show up in the right way. And I would hope that our trainees can hopefully feel empowered enough to hold us accountable too, if we're not demonstrating respect for them.
Speaking of maybe some of those more negative interactions, what advice would you give to someone if they are a witness to or the subject of a toxic interaction? And particularly as chair, if you've heard of these issues within the department or if they're brought to your attention, how have you managed them or advised people to manage them?
Well, unfortunately, by the time they get to me, someone's filed a complaint, and that's kind of the worst case scenario, because at that point, then there's some investigation of both sides and everyone is very defensive. And ultimately, in an ideal culture where there's psychological safety, what would happen is that someone would speak up in the moment, right? And say how, in whatever way they feel most comfortable, I'm not comfortable with this, or, redirect it in some way. We've done a lot of bystander training in our department to try to give people some tools and words to use, even if they're lower in the hierarchy. The ideal thing, which I tell all of my faculty, is, sometimes there's difficult days, hard cases, other things going on in our lives. We are not our best selves. That is just part of being human. Just recognize when you're not your best self and go back and apologize. The simple act of just saying, hey, I'm sorry, I barked at you, wasn't directed to you, I was frustrated or nervous about this case or whatever, I was up all night, whatever the reason might be, just humanizing the behavior and extending an apology will pay dividends in terms of building relationships and respect from others. Nobody is perfect all of the time, and we all have bad days. But I think it's sort of how you own up to it and manage it in the moment. So ideally, I think we all should find grace for others and recognize that other people also have bad days. And I think we also can get into this cycle when we end up in this reporting kind of environment, where I had this with a resident once that, they had clearly been reported on by a nurse in a prior case. And so then the blood had been forgotten back in the PACU, and should we write them up for this? And I'm like, no, we should just go get the blood. And I'm sure it was just a mistake. So I think, in my mind, once we get to this reporting culture, and we have lost the battle, because if that's the way that people feel like they have to communicate, then it's not a psychologically safe environment. So my ideal goal is that people speak up in the moment, and it often can be easier if the bystander is not the target of whatever the inappropriate thing is. So I think we all, again, are responsible for creating the culture that surrounds us. Certainly I have to set the example and expectations, but everybody has influence on that culture every single day.
Yeah, I love that example that you gave of empathy, of saying that we are all human and not everybody's going to be perfect all the time. And I imagine, as on any team within your department, there are different personalities, individual priorities. And so I think it's fantastic that you demonstrate empathy to your faculty members. But are there other sort of ways that you generate buy-in from faculty towards promoting a healthy culture? Or have you ever encountered resistance? And if so, are there sort of tactical ways or concrete steps that you have taken in order to still achieve that goal of having a healthy culture?
Well, I would like to say that, everything's perfect, but, we are fortunate to have a tremendous group of faculty, and we have tried really hard to cultivate a culture where certain behaviors are not okay. And people kind of know that. I think importantly, there's always two sides to every story. And so again, by the time I get pulled in, a lot of times it's just really trying to understand what happened, what was everybody feeling, because it's usually about feelings way more than anything else. And really trying to encourage conversations, because again, at the end of the day, nobody, I hope nobody comes to work and says, I'm going to be a jerk today or treat somebody poorly today. If they do, then we've hired the wrong person. So I think that as a leader, it's just really important that, not everybody in my department has to agree with everything that I say or do, but I need to be consistent and clear and transparent in what the expectations are and what the code of conduct is. And if someone is out of alignment with that, and not just with our departments, but the health system and the school medicine, public health, we all have to sort of be aligned with those expectations. And if we aren't, then again, we explain why we weren't, we apologize as is appropriate, and we try to move forward in a better way. If your question is really like, what do you do if that doesn't work? That's really what I'm hearing you ask, maybe.
Maybe.
I think those are hard, right? But in many ways, for me, those are, recently had a conversation with another chair who's, I feel like I'm still very new in my role, but they had just started in their role and had a situation with a faculty member. And I think for me, these are easy, because if there's behavior that's easy in quotes, because none of these things are easy, but if there's a patient care issue or there's a professionalism issue that is just clear, then the North Star is quite apparent in that situation, and you just have to follow it. So, and I think you have to really just be grounded on, there are certain things that are just not acceptable, and you can't make excuses for them, and you can't work around the edges of it. And we offer people help and support. And some people turn that around beautifully and are so grateful for finally having a solution for how to make this problem better that they've had for a really long time. And some people aren't. And the people that aren't, they just have to go. So.
Yeah, I think, leaders set the tone of any culture. You've alluded to this 30,000 foot point of view. And, I was wondering if you could talk about when you started as chair, or even now, if you think about your role in terms of molding your department and really creating a brand for your department. And there's obvious academic pursuits and research and everything else, but how does culture play into that paradigm or into that global view?
Well, I mean, I think everything is built on culture, right? So, and as they say, culture eats strategy for lunch. So you're going to have the perfect strategy, but if you don't have the right culture that supports and fosters, and I would say that was never more true than during the pandemic. Then nothing else really is ultimately successful or sustainable. You might make some progress, but then you'll fall back. So I think, one of the key things that I tell every potential faculty candidate that I interview, or during resident interviews as well, is that from my perspective, and I've been very clear about this since I arrived, is that one of the core values is that we will be collaborative and help each other, and all boats will rise. We are not going to compete with each other. The competition is not inside our four walls. So, and we don't, this idea that if, everybody's like working against each other, that we're gonna, make everybody like 10% more productive, I think is ridiculous. That just makes for a really unpleasant place to work. So I think that's an expectation. I'm very clear about that. We, when we realigned our compensation plan, it was with aligning incentives to support that thinking, because sometimes you can have misaligned incentives in your system that actually are pushing people towards behaviors that are counter to what you're trying to build. So I think that, anytime this comes up, which it of course comes up not infrequently, right? Endocrine surgery, otolaryngology, liver surgery, transplant, surgical oncology. And from my perspective, it is a huge benefit to have all of those perspectives at the table working together in the care of a patient, because everybody brings a different and unique skill set. And that is how we will approach it. So I think it's just being really clear and consistent about that. And then that, as long as folks know that that's the expectation, then if they're going to bring a proposal for a new program, it will include how we're all going to work together.
Yeah. No, that's a phenomenal standard that you've set, and that you're very clear about. So I can see how it would filter down into all the different divisions and everybody who all work together towards this goal. So just to close our conversation today, I wanted to ask that if you could describe the ideal surgical culture in 3 words, what would they be?
Well, of course, this is context specific, but I think from my perspective, I would say inclusive, collaborative, and transparent. I think if you don't have those 3 things, then you ultimately will be limited in what you can achieve.
Inclusive, collaborative, transparent. All right. I will even quote you if I say that in the future down the road.
I don't own those words for sure.
Thank you so much, Dr. Minter. I think that this was an important discussion to talk about, and to have someone like you who's in a leadership role and who set an example for so many of us. It's really been a privilege to be able to talk to you, and thank you so much for your time.
Well, thank you so much for having me, and great to see you all putting this all together. So
Thank you. Thank you so much.